I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, and I'm the host for the Vasculitis Foundation's educational webinar series. And I'm also a patient living with MPA vasculitis. So today's webinar topic is GCA vasculitis and current GCA clinical studies. And we are excited to have Dr. Sebastian Unizony with us today to educate us and answer questions. And now that all the housekeeping is done, let me begin by introducing Dr. Unizony. Dr. Sebastian Unizony is an assistant professor of medicine at Harvard Medical School. He co-founded and co-directs the Massachusetts Hospital Vasculitis Glomerulonephritis Center and Rheumatology Vasculitis Program. One of his research interests is finding better treatment options for patients with giant cell arteritis. And as such, he has ample experience designing and conducting investigator and industry-sponsored clinical trials in GCA. Welcome, Dr. Unizony, and thank you for being here today.
Thanks so much, Kathy and the Vasculitis Foundation. Thanks to the patients to take the time to join. So it's my pleasure. I really appreciate the invitation. I'm going to share my screen now. The idea is, as Kathy said, to do an overview, a brief overview of what GCA is. Most of you already know, you are experts in GCA. Then a second section on the importance of clinical trials. And then finally, clinical trials that are specific to GCA that are ongoing now. So, and we're gonna have, as Kathy said, some opportunity to discuss more and ask questions. So this is in Argentina, in the north. I'm from Argentina originally. And this is a little picture that I like to show with a gigantic cactus, me and my daughter. So the alternative talk for this, the alternative title, sorry, for the talk would be Battling the Giant, right? So let me begin the disclosures. I provide some consulting for companies. I obtain some research support from companies. And as you know, because in GCA, not many drugs are FDA approved, many of the drugs that we're gonna mention today, you need to be aware that are the use in GCA is off-label. And I listed them all there in the slide. So what is GCA? I think it's a common among the rare, right? It's a common rare disease, if I can say that. It's the most frequent type of vasculitis in adults. It's an inflammatory disease of the arteries, mostly involve the large arteries, as you know, the aorta and the main branches of the aorta. Has predilection for the extracranial arteries of the head and neck. So oftentimes patients are very worried about stroke. Stroke is very rare in GCA. It's exceedingly rare. It's mostly inflammation of the arteries that go outside the cranium. That's why some of the symptoms are headaches or jaw pain, right? Those are the arteries that are feeding structures outside the brain. So it's very rare to have inflammation of the actual arteries that go into the brain. So what is the classic patient? It's usually an adult or elderly patient. By definition, patients are more than 50, but the peak incidence is around 70, 75 years of age. Women are affected a little bit more than men, 2 to 3 times more than men. And it's mostly a disease of Caucasian patients, although it can be seen in other races, in Hispanic patients, in African American patients, in Asiatic patients, but most of the patients are Caucasian. How this disease presents, I like to divide the symptoms in 3 domains, if I can say, although they overlap. Some patients have a combination of this and that. Some patients have all of the symptoms. Some patients have symptoms only in one domain. But one of these domains is what we call cranial symptoms. So those are the headaches, right? The jaw pain when chewing, that's called jaw claudication. Oftentimes the scalp is tender on palpation, or when you put the head on the pillow, or if you're combing your hair. And then of course the visual symptoms that you are aware of. So blurry vision, double vision, rarely I would say vision loss. In terms of these cranial symptoms, the most frequent one I would say is the headaches. The characteristic it's not always the same headache. Classically, it's a headache in the temples, but it could be a headache located anywhere. The key feature is a new type of headache. So the patient usually doesn't have headaches, or the patient may have migraines or tensional headaches, but now there's a new type of headache that wasn't present before. That's more important really than the location. It's a persistent headache. It doesn't last 1 minute or two. It's there day after day. Again, temporal, sometimes it's occipital, sometimes it's the whole head. The jaw claudication is tricky to elicit sometimes. The classic one, the textbook is the patient starts chewing, and after a few seconds, there's significant pain in the jaw that makes the patient stop chewing, and the pain goes away. Sometimes it's not that clear, and patients report like tiredness. Sometimes there's some pain even without chewing that we are never sure whether it's really claudication, but I think there's a variety, or there's a spectrum, right, from the full-blown claudication to some equivalents, right? And then the visual symptoms. When I say that vision loss is rare, the bad one, the permanent vision loss is maybe 1 out of 10, maybe 2 out of 10 in older series. So most of the patients don't get vision loss. We'll talk about when vision loss happen. It's usually at the very beginning. Most of the time, the patient and the doctors don't know that the patient has GCA. They're doing investigations. That's when the vision loss will happen most of the time. More than 90% of the time of these cases of permanent vision loss is going to happen there. When the disease is recognized and the treatment starts, meaning prednisone or glucocorticoids, then the risk decreases dramatically. So it's not impossible to have vision loss later on, but it's rare. The second domain is the polymyalgia rheumatica. That is simply pain and stiffness in the shoulders and hips. That has to be inflammatory. Inflammatory to us means that happens after immobilization, classically when you wake up after sleeping, but it could happen after driving for an hour or two. So after immobilization, there's pain, there's stiffness, and activities, motion, after half an hour, 40 minutes, 1 hour, sometimes even more, make the pain and the stiffness better. Maybe not completely gone, but better. So that's the inflammatory rhythm. That's very important for us because there's so many other things that can cause pain, a rotator cuff tendinitis or osteoarthritis, but those are usually mechanical, so they come with activities. So this is the other way around. The third domain is what we call constitutional symptoms. Pretty much all the patients have some degree of fatigue or weight loss or decreased appetite. So that's frequently seen. It's very non-specific, right? When that's the main symptom, it's difficult to make a diagnosis. Usually it's important to recognize the cranial, the PMR symptoms. That helps a lot with the diagnosis. And then most people, over 95%, I would say, when we check blood, we find these serrates and CRPs that most of you are familiar with. Again, serrate CRPs are important because they are reflecting an inflammatory state of the body, but they are not telling exactly what it is. You can have the same inflammation if you have a pneumonia or if you have some other inflammatory disease. But usually the combination, your demographics, the right age, the right clinical symptoms, the increased inflammatory markers, that's the pattern, that's the combo that we put together to suspect or not giant cell arteritis. So until a few years ago, the only thing we could do to try to confirm the diagnosis was a biopsy, right? Looking for inflammation in the temporal arteries, because the temporal arteries are very easy to sample. They're easy, the rate of complications of a TA biopsy is very low. So historically, that was the only methodology or methods for making a diagnosis. In the last 20 years, and even more in the last 10 years, this area is exploding for the good, right? So we can do ultrasounds of the temporal arteries, again, in the right clinical context. those will spare patients a biopsy, which is great. What the technician or the doctor is looking for is inflammation around the arteries. Here in this picture, you see a normal looking artery by ultrasound, in which the wall is very thin, maybe 1 millimeter or 2. In the middle, you see the blood flowing. And when there is inflammation, you see this thickening halo, right? This surrounding circumferential dark material, that's just inflammation or edema. And that is the hallmark of GCA. That's what we call halo sign. So again, in the right clinical setting or context, then you close the case, which is great. And not only we can use ultrasound in the temporal arteries, but we can use more advanced imaging techniques, CTAs, right? MRAs, PET-CTs, more often nowadays applied to the large arteries, right? To the chest, where the aorta and the main branches are. These pictures are examples of a CT angiography or an MRA or MR angiography or a PET-CT. They're all showing different lesions that are very suggestive of vasculitis. And again, in the right clinical setting, that means GCA. And then more recently, the opportunity or the possibility of doing other types of imagings of the extracranial arteries, like an MR type of image or even a PET. These last two are newer, so they're still evolving, but we are using them in clinical practice more and more, especially the MR, and soon, hopefully, the PET. The PET still is a little bit in the research arena. But this is just to tell you that that is good news, right? We have a toolbox. In the old days, we used to, quote unquote, fight about what's better, biopsy versus ultrasound. Everything is good in the right setting. It depends on the access. It depends on the experience of whoever is doing the test. So whatever is available is welcome. So there are pros and cons of all of this, but they all belong to the same toolbox, and we use them in different situations as needed. So this is great news. The other piece of great news is that the availability of guidelines. Now you go in the States in 2021, the American guidelines were published. We published guidelines for Latin America last year or a couple of years ago. And then there's guidelines in Europe that soon are going to be updated. So there's resources for providers everywhere, and this is great, right? This is spreading the voice about what is the best way of treating patients with GCA. The unfortunate part is that we still have only a few well-established treatment options, and part of this webinar today is to discuss what's coming. But so far, well, there's a clear role for steroids. There's a clear role for this medication called tozcilizumab and for this other medication called methotrexate. There are some other medications that we use that I will mention, and there's a lot of medications coming down the pike. So it's an exciting time for GCA, not only for diagnosis, right, but also for treatment. When I started more than 10 years ago, there was only prednisone and maybe methotrexate. So now things are changing fast. So I think this is, Kathy, the first part.
Yes, this is where you can stop sharing your screen for a minute. We had we've had a few questions, so I'll start with them. And I did want to tell everybody one thing that I forgot to mention at the beginning is that Dr. Unizony will do his best to answer your questions, but he may not be able to specifically answer your questions about yourself because he's not your doctor. He will do his best to answer you generally. The first question, I think you answered actually in your presentation, but let's ask it anyway. After being on a treatment plan for 2 years with no flares, is there a possibility of losing vision as prednisone is reduced? I'm presently on 3 milligrams. I have been on 5 or less for 2 years.
So as I said, if you see the patient that lose vision, you'll find that more than 95% that event occurred very, very early on, most of the time even before prednisone, and then it's very rare to happen during follow-up. Of course, it's not impossible. When you read the series, there's always one case or two that may happen even years down the road. But I think the overall theme here is reassurance. So it's very unlikely, it's very rare to have vision loss, particularly if someone has been in remission for a certain amount of time. So the longer you go without a flare, the less likely that you're gonna have a flare with vision loss. Still, I like to give my patients these 60 or 80 milligrams of prednisone for emergencies, and I'm very clear on what an emergency is. I don't want them to start taking prednisone for PMR. I want them to call me if they have PMR. If they have headaches, I want them to call me. But if they have 3 things or 4, all of a sudden they cannot see from one eye, all of a sudden they are seeing double, all of a sudden they are having what we call amaurosis fugax. They don't see, after a few minutes they see again, right? That comes and goes. Or there is this episodic blurry vision, right? Few minutes, not 1 second, few minutes, 2 hours, the vision is blurry, then it gets better, then it gets blurry. So those things are emergencies. Then 60 milligrams of prednisone, 80 milligrams of prednisone, different patients are different, so it's good to discuss with your rheumatologist. And not only that, you take the medication and you go to the ER, the closest ER, and then you call your doctor from the ER. We don't want you to stay home waiting for your attending to return the page, right? So these worrisome visual symptoms, you need to have your emergency prednisone kit, and you need to identify your ER or the place you're gonna go and see. Again, that's gonna be unlikely to happen.
Okay, thank you. This next one is about when you were discussing the different imaging techniques, temporal, artery, ultrasound, and advanced imaging techniques. Are they not subject to the skipping that biopsies can be subject to and actually missing the diagnosis?
Yeah, so one of the advantage is that the biopsy is gonna take only a segment, and it's true, you are at risk of missing the segment or the place that was inflamed because the lesions are skipped. But this imaging are gonna cover a good amount of the vasculature, right? With the ultrasound, you not only gonna assess the temporal arteries in all the longitude, but also the occipital arteries. With the cross-sectional imaging, you're gonna assess the whole aorta and all the branches. So you're gonna have plenty of opportunity to pick up that lesion, either a wall thickening or contrast uptake or stenosis or narrowing. So you're gonna have more opportunity. Each technique has what we call sensitivity and specificity, which tells you about how often the study can be negative, even if you have the disease. They are not perfect. They all have some percent of situations in which you can still have the disease, but the image didn't show it. And they all have some small percentage of the image is showing an abnormality, but it's not GCA. It's another disease.
Okay, thank you. And another question about, I guess, diagnosis and various types of that you would use for that is, what is the most common diagnostic test used for ongoing monitoring of the disease?
So the ongoing monitoring is mostly relies on clinical grounds still, even if there's a lot of research to try to find that biomarker or to try to find that utility of the ultrasound or the PET-CT. Still, the main way of monitoring and declaring whether someone is flaring or not relies on clinical grounds, recurrence of symptoms, even more than the laboratory abnormalities. We use the cell rates and the CRPs. They are very useful, but they are not the whole story. The main piece of source of information is signs and symptoms, a doctor that is comfortable and experienced in following patients with GCA. That comes first. We use the labs, and we are trying to find those lesions or changes in the imaging that will also support whether you are in remission or not. But we are not there. We haven't found that biomarker or that lesion that will unequivocally say someone is active or in remission. So we continue to work in that area. There is some hint on ultrasound in some situations, or PET in some situations are very suggestive of activity, but there are many cases that are not that clear.
Okay, and this question is, are there any genetic predispositions to GCA?
Yeah, there are. GCA is not it doesn't run in families, although there are some reports of familial aggregates, but most of the cases are just isolated. But there are some genes that predispose you to have GCA. The risk of those genes is not very strong. There's so much that we still don't understand, because the risk of having those markers, again, it's not that high. So there must be something else, some type of exposure, something that we don't know yet. But there are some genetic markers that we don't use in clinical practice. Those are mostly research based. But there are some of these genes have to be with markers of the immune system, the major histocompatibility complex, some molecules that the inflammatory cells express in their membranes. So some version of those molecules are more frequently found in patients with GCA than patients without.
Okay, and I'm going to do one last question, and then I want to remind everybody that there's going to be a follow-up email, and you will get a link to a much longer webinar about GCA specifically that Dr. Unizony did last year. And that's a great way to get most of these answers that we don't get to today. And the last question I was going to ask you is, somebody's asking about relapse rate.
So relapse rates depends on the treatment that the patient receives. So roughly speaking, right, if someone gets only prednisone, oftentimes patients only receive prednisone. Roughly speaking, between 50 to 60 plus % of the patients may relapse, usually when the dose of prednisone goes below 10 milligrams, rarely when the doses are above 10 milligrams. It depends a little bit on the study that you are reading and how relapse was defined in that study. Some studies define relapse as recurrence of symptoms with or without inflammatory markers. Some studies define relapse as both symptoms plus inflammatory markers, and some studies define relapse as either or, recurrence of symptoms or increased inflammatory markers. So the last way of defining a relapse is probably not the best one, because oftentimes we see a spike in the inflammatory markers without clinical symptoms, and for many of us that needs to be monitored, right? We need to open the eyes, but that wouldn't be a flare, right? So the best way to define flare, in my opinion, is the recurrence of the symptoms, with or without the inflammatory markers. When you define it that way, 50%, 60%, 65% of patients that receive only prednisone will relapse. When you use a medication like Actemra or tozcilizumab, then the rate of relapse decreases. We don't have a lot of information on the long-term use of Actemra, but when you're talking about 1 year or 2 years of use, the relapse rate is probably between 20 and 30%, little bit less, little bit more. So it's much better than when you receive prednisone alone. So those are some rough numbers.
Okay, well, thank you so much for that. You know, we're going to stop for a minute now, and I'm going to actually give you all a poll to fill out. So if you'll all look at your screens, there's a poll that should be popping up asking you a few questions. I think it's 4 questions, so scroll down to make sure you get to all 4 of them. I'm going to give everybody about a minute to get in there and populate your answers, and then we will show the results to everybody and show the results to Dr. Unizony, and let's see if he has any comments about the answers. So giving everybody just a little bit longer. There you go. I think you can see the results, Dr. Unizony.
Yeah, so essentially less than 20% of the participants have been on a clinical trial or know about a clinical trial, and the opposite, 80% probably would participate or would be interested to know more about trials. So the next section is going to be very useful, hopefully, for this 80% and the rest too. Should I share my screen again? Let's see.
There you go.
All right. So this is the first part of this clinical trial section, is to discuss some concepts about clinical trials, give you something to think about and ask questions. Doesn't mean to be an extensive review of clinical trials. And then at the end, I'll show you some of the clinical trials that are ongoing in GCA. So the first slide is, okay, this is what we use on a daily basis: prednisone, tozcilizumab, methotrexate, 3 medications. This is what we use for rheumatoid arthritis on a daily basis, more than 15, 16, 17 medications. So why rheumatoid arthritis patients, why the treatment is so different? Well, I think it's mostly because they've been doing things earlier than us, right? There's been plenty of clinical trials. So the way to get there is through research, and mostly through this type of research called clinical trials. So then you can rule out things that don't work and then increase the list of things that can work. So in patients with rheumatoid, when something fails, it's amazing how many options we have. So hopefully we'll have the same type of landscape, right, for GCA within a few years, not too many. I think we're getting there. So this is a cartoon that you're not supposed to remember after this talk, but this is very schematic of the inflammatory cells that are there in the arteries, causing inflammation in GCA, and some of these molecules that are perpetuating the inflammation. So those are opportunities for intervention, right? Try to block the signaling of all these molecules. And then in the left, you have all the medications that are currently being studied, and we'll mention them later on. So don't worry if you don't remember them right now. So why clinical trials are important? Because clinical trials are the most rigorous type of clinical research that will identify new treatment options. So other types of research, what we call observational research, is very important because we learn a lot. But when it comes to really assess the efficacy of a drug, the safety of a drug in a very rigorous manner, nothing beats clinical trials. Again, as I have here in the second bullet, you can, if the trial is properly designed, right, we talk about power, right? If you have the right number of patients, you got the right assumptions, you plan it very well, you can unequivocally demonstrate that the medication works or doesn't work. You can get a lot of information about safety. You can rule out important side effects. You can detect signals of safety. And most of the medication that will go on and be approved by regulatory agencies, more often than not, will require a clinical trial to back up that application, right, for approval. So this is just some terms that you may hear when you talk to doctors about clinical trials. Some trials are investigator-sponsored, and some trials are industry-sponsored. That means basically who is the ultimate responsible party designing the clinical trial. And in GCA and in vasculitis and in medicine, there's both. Sometimes investigators have a great idea, they put it on paper, and they apply for funding, and then they conduct the clinical trial. And sometimes there's a partnership with the industry, but the industry takes a more active role, and they actually design the study, and then they communicate and collaborate with investigators in hospitals, right? And then the trial gets done. The trials sometimes happen in one center. More often, the bigger trials, the ones that are going to end up in an approval of a medication, are multi-center, especially in diseases that are not so common, so you can do your trial faster. You'll see that there are phases, phase 1, 2, 3, 4. The phase 2 and phase 3 are what you're going to hear more in GCA. The phase 2 are smaller trials, usually less than 100 patients. They are more exploratory. And then once there's a signal that the medication can safely or probably safely maintains remission or is effective, then usually there's a phase 3 or more than one phase 3 confirmatory studies, like Many of you may know this GIACTA trial that led to the approval of tozcilizumab. That followed a prior study done in Switzerland that was a phase 2 study. So that's a common path. First a phase 2, followed by a phase 3. You'll see that many of these studies are blinded, and some of them are open label. What does it mean? Blinded means that there's gonna be more than one group of patients, right? Or more than one type of intervention or treatment. And blinded means that the provider, the doctor, and the patient will not know exactly in which arm, right? What specific treatment they are getting. That's important to prevent bias. Sometimes when we know what the patient is receiving, we're gonna have some conscious or unconscious bias. Sometimes the patient will say, I have some discomfort in my shoulders, and maybe if we know the patient is on X treatment, we will say, well, maybe it's nothing, you are on the right treatment, and we may miss a PMR flare, or the other way around. So the most rigorous way of assessing clinical symptoms and laboratories, right, in the setting of a trial is if we don't know what the patient is receiving, and the same applies to the patient. The patient might minimize their symptoms if they know they're on a medication that could work, etc. So another concept or word that you'll see is the placebo-controlled trial. That means essentially there's going to be patients receiving the active drug, right? The drug that we're going to try to see if it works, and the other group will receive a placebo that looks exactly the same. That's essentially by doing a placebo-controlled study, you're going to prevent unblinding, right? Because everyone is going to get exactly the same pill or exactly the same infusion, right? One is going to have the active ingredient and the other one is going to be a placebo. Sometimes there's a placebo effect whenever you receive a medication, even if it's an active ingredient or a placebo, your body, your psychology may react differently. So including a placebo will, if everyone in the clinical trial gets something, right, either a placebo or the active medication, you're going to cancel that placebo effect. Most of these studies are randomized, which means that it's by chance who gets assigned to one arm or to another. That's a way of making sure that all the characteristics, the age, the sex, and all the characteristics of the patients are evenly distributed. If you leave that to random, then it most likely is gonna get balanced, and then you don't need to worry about that, right? That's already done. So now you can focus only on whether the treatment is doing what you want or not. We'll review in the next slide. The clinical trials are very rigorous. There's a lot of thoughts that go into the trials, and there's an independent body that will review the protocols to make sure that safety is first, that it will advocate for ethics and well-being of patients. That's the IRB here in the United States. In Europe, they're called ethic committee. Essentially, they review, it's a multidisciplinary group of people that review the protocols in detail to make sure that they are acceptable, right? The risks are not high, there's good plans for mitigating risks, etc. And then the final word in this glossary is the informed consent. If you go in a clinical trial, you'll meet with your doctor for at least 1 hour, and you'll review a long document that is the informed consent that will have essentially what's going to happen in the clinical trial in detail. It's going to have a lot of information about the medications that you may receive, information about what if this happens or not. So it's very important to take time, review the consent, and make sure that you understand, ask questions. If you need to ask 3 times, you ask 3 times. Make sure that you understand exactly what's going to happen in the clinical study. So there's 2 big bodies of guidelines and standards when it comes to practicing clinical research and clinical trials. One is the so-called Declaration of Helsinki, and the other one is these guidelines for good clinical practice. So whoever is designing the study, either the investigator for an investigator sponsored or the industry, they will comply, right? They will take all this guidance in consideration when we are or when they are doing the design of the trial and the conduction of the clinical trial. So as I said, there's a lot of thoughts in the planning. You really need to think about everything before you launch the study. You need to consider all the potential outcomes, right, and have a plan for everything. If it's an industry sponsor, oftentimes the industry seek input from experts, right, to help design the study. Often seek input from the FDA. Again, safety is a priority. In the clinical trials in GCA and in most diseases, there's always a standard of care or an acceptable variant of standard of care that everyone receives. So it's not that there's going to be a group of patients that don't, if the patient that get the placebo, it's not that they're going to be left alone without treatment. No, everyone will get a baseline treatment, and then a group will receive an extra intervention, and the other group will receive the placebo. In GCA, still that baseline standard treatment is going to be some amount of prednisone, more or less. But that way we make sure that everyone is going to be taken care of, there's not going to be risk of vision loss, etc. In GCA, most of the medications that we are testing nowadays are already in use for other indications, which is good because from talking to patients, they feel better when they know that the medication has already gone through clinical trials for rheumatoid arthritis or psoriasis, because they have been in the scope for many years. So that provides us another layer of reassurance. As I said, all these protocols have different safety measures, right? Labs or evaluations at different times in time points, etc. All the protocols have these escape options. If you have a flare, then we can use prednisone. If the patient prefers not to continue in the trial, or the provider thinks that it's a good idea to stop the trial, that's easily done. And then another important thing of most of the clinical trials in GCA is that most of the protocol have a second part, right? The first year, more or less, is this randomized placebo-controlled trial, and then there's an extension or part 2, in which there's open label access to the medication in case there's a flare during that part 2. Sometimes that's a good compromise for those patients that say, okay, I'm going to enroll in the clinical trial, but if I have a flare close to the time where the first part is ending, then I could potentially get the medication for the part 2. So that's something good. It's another option. We can terminate the study and go to plan B, tozcilizumab or methotrexate or only prednisone. But if that flare happens towards the end, then there's access to the medication. Again, the medication is being studied. We don't know yet if it's going to work for all the patients, but at least it's available for the duration of this part 2. So these are examples. Most of the medications that you see that are successes in the last 10 years or so in vasculitis come from this type of randomized placebo-controlled clinical trials. So here in the left, you have a bunch of GCA studies. You have this GIACTA, the one that led to the approval of Actemra. There's a phase 2 of a drug Mavrilimumab that I will show you later on. There's a phase 2 of a drug called Secukinumab that I will show you later on. And then there's a medication recently approved for PMR. There's some people that only have PMR without GCA. So there's a medication now approved for that. And then on the right, you have some other good successes in ANCA vasculitis, for example, rituximab, Abatacept, Mavrilimumab. So we really need these clinical trials to continue moving forward and finally get to these 17 different medications, right? If one fails, then you have this other one. So that is the second part. I think I go directly, Kathy, to the last part, right? Sorry, I put you on the spot.
Sorry, say that again.
I continue and we take questions at the end.
Yes, We're going to take questions at the end of your presentation.
Thank
And as long as you've said that, I'll make sure I tell people we're going to take clinical trial questions at the end.
Okay. All right. So these are a few slides about things that are happening in GCA right now. Some of these medications have results available. There is a study that is already out there with results, and some we're waiting for the results. So I will mention 3 that have results, 3 phase 2 studies, smaller studies, preliminary data. One is with this medication that we use for many, many years in rheumatoid arthritis called Abatacept. So there was a study a number of years ago in which all the patients got Abatacept and prednisone, all the GCA patients, and the ones that entered remission at week 12 were divided in 2 groups. One group continued the Abatacept infusions plus the tail of the prednisone taper, and the other group got a placebo, right? So they don't get unblinded, and the rest of the placebo, and the rest of the prednisone taper, sorry. And the outcome was, okay, how long is it gonna take for this patient to have a flare? And the study showed that there was a difference favoring Abatacept. There were less patients flaring on Abatacept within that first year compared to placebo. The second study is a study that we did in many centers. Me and Maria Cid from Spain were the PIs, and the study is with a molecule called Mavrilimumab, also tried in rheumatoid arthritis a number of years ago. So now there's a good rationale that the medication may work for GCA. And in these phase 2 studies with 70 patients, the results showed that it was a phase 2, was a small study, and the primary outcome was measured early at 6 months. And it showed that at 6 months, over 80% of the patients that received Mavrilimumab plus prednisone were in remission compared to 50% of those that receive a placebo plus prednisone. So promising results with Mavrilimumab. The third one is the Secukinumab. It's a medication that, again, has been in use for a number of years for psoriasis. And there's, again, good rationale that blocking this IL-17, that is the target of Secukinumab, could be important to downregulate some of the inflammation in GCA. So in this phase 2 study, again, with an endpoint that was early, showed that if the patients were, the group of patients assigned to Secukinumab plus prednisone did better, were in remission 70% of the time at 6 months and 60% of the time at 1 year, compared to those that got the placebo plus prednisone. Those were in remission, only 20% of them were in remission at 6 months, and 8% of them were in remission at 1 year. You'll see that the flares are more often in clinical trials because usually, remember when I said that everyone gets the standard of care or a variant of the standard of care. In clinical trials, usually everyone gets prednisone, but oftentimes the prednisone tapers are a little bit shorter because that's going to create the good condition for showing that the medication that you're testing works or doesn't work, right? There's going to be flares, and then if the medication really works, you're going to see it. If you give a lot of prednisone, right, for a long time, most likely everyone will be in remission, or many patients will be in remission, and it's going to be more difficult to really show the difference. All right. And then there's several studies that are ongoing. So there's a confirmatory study with Abatacept that is recruiting patients. There's a confirmatory phase 3 study with Secukinumab that is recruiting patients. There's a study on a medication called upadacitinib or rinvoq, also used in rheumatoid arthritis, that has been recruiting patients for a few years now, and hopefully will have results soon. There's a study that just completed recruitment. So now all the patients need to finish the trial protocol with a medication called guselkumab, a phase 2 study to get some preliminary data. So we'll wait for those results. And then there's a study done in France in which methotrexate is going to be compared, or is being compared, to tozcilizumab, both on a prednisone background. the last part is about prednisone, right? So we started historically patients with GCA, when they receive prednisone alone, usually it's never less than 1 year. It's an average 1.5 years or 2 years if you don't have a relapse. And then if you have a relapse, that prolongs things because you need to increase the prednisone and start the taper again. So from those long prednisone tapers nowadays, with the use of tozcilizumab or methotrexate, or these medications that we are studying that I just showed you, we're trying to shrink that taper to 6 months, more or less. But 6 months still a lot of steroids. So the hopes is that in the future we can do less than 6 months. In ANCA vasculitis, for example, now we have a treatment that can almost replace the use of prednisone. So we really need to go and use less than 6 months. So there's been some small studies. These are not randomized placebo-controlled studies. These are just pilot studies. This one was in Switzerland, done in Switzerland. Patients only received 3 injections of steroids plus Actemra or tozcilizumab. That's the only prednisone they received. They didn't receive any oral taper. That was a very provocative design. And then 70% of those patients were able to maintain remission for 1 year. Again, this is in a research setting, very controlled, very selected patients. So this is not to apply tomorrow in clinical practice. This is just to give you an idea that it's likely that there's a version of a prednisone taper that is probably less than 6 months that needs to be proven properly, probably through a randomized controlled clinical trial. But there is hopes that we could probably use in the future less steroids. And this is a study that we did, very small, again, with 30 patients, in which we use only 2 months of prednisone plus tozcilizumab. And we found that in that protocol, 75% of the patients were able to stay in remission for at least 1 year. So again, this is not to use tomorrow or go to your provider and say, hey, I just want to use 1 month of prednisone, because this is still in a preliminary phase, right? But it's a positive preliminary, it's positive preliminary data. So ultimately, in the next few years, I'm not talking about 20 years, but maybe 5 to 10 years, the idea is to have more than just 3 options, right? That are effective, that are safe, that they minimize the use of prednisone. We are using more questionnaires of quality of life, because doctors were just focused on relapse, no relapse, how much prednisone did you use? And for the patients, that's important, but oftentimes it's, I'm fatigued, I don't want to go out, etc. So, and we are not thinking about those outcomes. So now we are, and most of the clinical trials have different measures of quality of life. So we really need to show that these drugs not only keep people in remission, but that the patients feel good, right? The quality of life improves. And then this is also pending. You know that there's a percent of patients, maybe 20% or so, that may develop an aneurysm, for example, what we call arterial damage. So the idea at some point is to also prove, or try to prove, that these medications prevent that. But that's a little bit more difficult because you need long time, right? Those lesions don't happen within a year or 2, usually need more than a few years to happen. But that's where I think the ultimate goal of treatment, or that's where the landscape for the treatment of GCA should be in the near future. So these are useful resources. That's one is the talk I gave that is similar to the first part you hear today. That's the second one is clinicaltrials.gov. If you go there and type giant cell arteritis, you're going to have a list of the trials that are ongoing, the sites with phone numbers, right, ways to contact the investigators, and then a link to the amazing research that the Vasculitis Foundation is doing, collaborating with other vasculitis investigators. All right, so I'm ready to take some questions or hear some comments.
Felipe,
Okay, you take a break with your voice for just a minute, and I am going to ask a couple of questions. I want everybody to realize we don't have many more minutes left in this webinar, but we're going to do the best that we can. And I did want to say also that there will be a follow-up email with more information. So thank you all for participating. The first question is a great question. What is the difference between a clinical trial and research? Like research being done at the Mayo Clinic in Rochester, Minnesota on GCA.
Well, research is everything, right? Research is basic research when you are studying not patients, right? You are studying animal models, molecules, right, in the laboratory. Then you have clinical research, and there's many types of clinical research, and clinical trials are just one type of clinical research. And then you have something called translational research that tries to bridge both. So you are probably using samples from patients, right? That's clinical samples, but you bring them to the lab to do some more basic experiments or analysis. So basic research, translational research, and clinical research. And the clinical research could be, very broadly speaking, what we call observational, when you're just analyzing things in a group of patients, but you're not making any intervention. Let's say you identify 100 patients with GCA in your hospital, and you want to see how many of them had a relapse, right? That's observational research, or interventional, experimental clinical research. And that's a clinical trial. So you are making an intervention.
Okay, great. Well, thanks for explaining that. I'm going to ask you a few questions in one group because I really think they are all questions about how to get into a clinical trial. First one is, what role does attending a treating physician play in the patient's participation in a clinical trial? Also, are newly diagnosed patients eligible for studies, or do they need to live near the facility? Let's try those few first.
Yeah. So most of the clinical trials enroll both patients with new onset disease or with relapse. Sometimes a trial enrolls only new onset disease. So each trial has a protocol with some difference, but usually it's both. Most of the trials need that the patient has activity now or recently. If you had a flare 2 years ago, most likely, most of the studies, for example, that are ongoing now with all these medications, you wouldn't qualify. But if you had a relapse 3 weeks ago, most of them have this active disease within 6 weeks, more or less, right? It's important to be relatively close to the center because, or not, but I'll explain you why. Most of these trials see patients every month or every 2 months or every 3 months for 1, 2, 3 years. So there's many trips to the center. So if you live far away, it's going to be more complicated. But some people do it. So, and then attendings. So many attendings know about where trials are happening. So sometimes you can talk to your attending or to your rheumatologist, and then he can connect you with a trial site, for example. But not all. So there's some rheumatologists that don't have an interest or are not connected with other investigators. That's why this clinicaltrials.gov is important if you want to advocate for you. It's always a good idea to discuss with your rheumatologist. Probably it's not good to just don't tell him anything and then call the site and say, hey, I'm going to be seen. You can do that too, but usually rheumatologists and other providers are reasonable people, so you can have a discussion and most likely you'll create a plan together.
So interesting question that somebody brings up is, why should I be interested in a clinical trial if my current treatment protocol is working successfully? And I think along with that, it's important to actually answer, why as patients, I'm a patient, why as patients is it important for us to participate in clinical trials?
Yeah, it has many answers, or the answer has many parts, and there's no one absolute truth, right? There's without patients, there are no clinical trials, and science doesn't advance, right? That we know.
Mm.
But not every patient has the personality or the characteristics or is willing to consider a clinical trial. I understand. Many times my patients say, well, you are presenting me with an option of prednisone alone or prednisone plus tozcilizumab that is FDA approved, plus this clinical trial. I don't want to go in a clinical trial that half of the patients or 30% receive a placebo. And that's perfect. That's your opinion. That's the beauty of shared decision. It depends on the protocol too, and it depends on understanding. Okay, the treatment right now is prednisone, tozcilizumab, and methotrexate, right? Roughly speaking. Okay, how effective are they? How safe are they? So maybe you'll find out that they are not 100% effective or 100% safe. So then, depending on the clinical trial that is being presented to you and the rationale behind that trial, you may change the way you think, and maybe you feel that what you thought it was the thing that you really wanted has some limitations. Some patients have a contraindication for some of the medication some patients have contraindications for tozcilizumab, and then that's a good rationale to explore other alternatives. But at the end of the day, it's not right or wrong. You own your body and your fate. So it's okay. I think the key is to really have that open discussion, take enough time to discuss, ask all the questions, and then you'll decide. Sometimes the clinical trials are built in a very appealing way that there's many ways of escaping to plan B, right? And then you say, okay, I'm going to give it a try to this clinical trial because it's safe, the medication is well known, there's a good rationale that it may help, but then I know that if I don't do fine, I will quickly go to plan B. So those are things that are at play when you are deciding what to do. Yeah.
I think that does help answer quite a few of the questions that were here. I'm going to ask you one more question because we don't want to torture your voice much longer.
I'm okay.
And this question, I never would have dreamed that it would come up today, but are there any post-mortem studies underway? And if so, are they being conducted? If so, where are they being conducted? And can someone sign up ahead of time to be a post-mortem study?
I don't know to the top of my head of any ongoing post-mortem study. I know there's a classic post-mortem study often referenced in the literature. I think it's from the 70s or even before, in which they analyzed inflammation in the arteries of patients with GCA, and most of the patients had at least a little bit of inflammation in the arteries. I know also that many institutions like MGH or big hospitals, or potentially any hospital, but I know for sure at MGH you can sign in your goals of care or your wishes for the future that in case you die, right? you undergo an autopsy, so
Right.
people can learn that is in place in MGH. We don't discuss that too often. Maybe we should do it more often because there's so much things to learn, and if there are patients that are willing to
Yes, an interesting question right there at the end. And I'm afraid we are out of time today. And as a reminder, today's webinar will be published on the Vasculitis Foundation's website soon. Each person registered for today's webinar will also receive a follow-up email with links to all of the studies that Dr. Unizony talked about today. And also, a lot of you did have more questions about GCA disease. First of all, there'll be a link to Dr. Unizony's 2023 webinar that might answer your questions, but we will also, as we always try to do, we will also at some point gather these questions and do a follow-up webinar with answers to these questions. We don't want to leave any of you hanging. We'll do the best that we can. And today we would like to finish up by thanking Dr. Unizony for all his time. I can't tell you how many people in the chat box said thank you. So lots of them did. So we appreciate the time that you gave us today and the information you gave us. We'd also like to thank our sponsors today, Novartis and AstraZeneca. We appreciate their sponsorship. And of course, the Vasculitis Foundation for hosting these important educational webinar series. So thank you, Dr. Unizony. We so appreciate you today.
My pleasure. Thanks so much for the invitation. I enjoyed a lot. So happy to participate in another webinar at some point.
Great. Thank you. Thank you, everyone.